We'll conclude this part of the course talking about best practices for the chiropractic care of older patients. Recently, there has been an increased focus on the implementation of best practices in medicine and all forms of healthcare. The spinal pain world is no different, and you might be familiar with what were referred to as the Lancet papers that were published in 2018. These papers highlighted the need for a multidisciplinary approach to the care of low back pain, and the author group featured prominent chiropractors in our research world. What the Lancet papers told us specifically is that currently low-value care is being provided much more than high-value care for low back pain. What we know based on other parts of the literature is that that situation could be even worse for older patients. When the Lancet papers were published 3 years ago, they received a lot of global media attention. There was a general sense of shock as to the horrible scenario being played out in healthcare relating to the care of low back pain. A logical question at this point is, has anything changed? Is anyone reading research and integrating it into practice? It's been my opinion throughout my career that if no one's reading and integrating research, then what's the point? So let's look into this from a low back pain perspective. In 2017, the American College of Physicians published a widely distributed low back pain clinical guideline, highlighting important aspects of clinical care and making specific recommendations based on the existing evidence. Since that time, some things have changed. For example, Tylenol, that we'll talk about later in this course. But these guidelines recommended the following for subacute low back pain. Non-pharmacological care first, including heat, massage, acupuncture, chiropractic, and simple NSAID medications and maybe even muscle relaxants, but no opioids. For chronic low back pain, they also recommended non-pharmacological care first, including exercise, rehabilitation, chiropractic, acupuncture, mindfulness, biofeedback, laser, and other interventions. For chronic low back pain, they went on to further recommend that if non-pharmacological care isn't working, adding NSAIDs and only weak opioids if needed was recommended. Patient education, the avoidance of overimaging, and other concepts were also explored. Does this all sound familiar? This is what should be happening in primary healthcare for spinal pain syndromes. So what does the report card look like on how we're doing from this perspective? Are primary healthcare providers integrating evidence from these clinical practice guidelines? Well, these days we actually investigate these things from a research perspective. The next two papers I'll discuss look at whether family physicians are actually following these clinical practice guideline recommendations. The first paper was a patient survey, so they went to patients and asked them what their family doctors were telling them about their low back pain condition. This is what they found. The patients told us that most physicians recommended a combination of drug and non-drug approaches, usually prescription medications and self-care, as follows. 62% of patients reported receiving a recommendation for opioids, benzodiazepines, gabapentin, Neurontin, or cortisone injections. This is quite simply not following clinical practice guidelines. 76% received a recommendation for acetaminophen or NSAIDs. Again, we'll talk about the downfall of Tylenol in a few moments. Only 37% received a recommendation for spinal manipulation, massage, or acupuncture, but at least 60% of them got recommended to seek care from a physical therapist. Overall, the majority of patients followed their MD's recommendations, but many of them used non-drug therapies without telling their primary care physicians. This sort of behavior has been demonstrated in other parts of the literature as well. Overall, this study shows us that there's a significant gap between physician behavior and existing clinical practice guidelines. This second study surveyed the primary care physicians themselves, asking them about their low back pain clinical guideline implementation in their own offices. They conducted structured interviews with 72 MDs. Only 75% of them were familiar with the 2017 American College of Physicians guideline on low back pain. For acute low back pain, 81% of them claimed to provide advice to stay active, and 97% said that they recommended pharmacological management mainly with NSAIDs. For chronic low back pain, 78% reported recommending physiotherapy, but only 21% for chiropractic, 18% for massage, and 17% for acupuncture. Shockingly, for acute low back pain cases, all of those recommended treatment modalities that are in the clinical guideline were not recommended by MDs, a whopping 0% of the time. That is a critical gap in the knowledge between the clinical guidelines and physician behavior. As you can see, there's certainly room to improve in terms of how family physicians implement clinical practice guidelines. Those American College of Physicians guidelines on low back pain are merely one example, but I'm sure the data would reflect similar behavior for other musculoskeletal guidelines. In a discussion about best practices, we have to discuss imaging for a moment. This is quite simply an ongoing problem in healthcare, specifically with regards to spinal pain. It's well documented that over-imaging is still a problem in healthcare. It is simply overutilized for most spinal pain conditions. A recent paper published discussed some reasons why this may occur, and these may sound familiar to you. First, patients may expect imaging will provide valuable diagnostic information that will then inform appropriate management. Patients have a hard time understanding the lack between anatomical specificity of diagnosis and the proposed plan of treatment and what it could do for them. Second, clinicians want to reassure the patient by ruling out serious conditions. This is certainly a good reason to seek imaging, but it's certainly not a reason that exists across the board for spinal pain patients. Third, this paper revealed that clinicians also feel obliged due to entrenched beliefs about imaging, fear of litigation, and perceived pressure from patients, and also in some cases financial incentives. All of these factors work together to produce an environment where imaging is still overutilized for spinal pain. A recent paper published in the chiropractic literature by Dr. Myberg and colleagues looked at shared diagnostic meaning via imaging reporting. Ultimately, these authors aim to explore the MRI report itself as a healthcare encounter for generating shared diagnostic meaning. This is again a patient-centered way to look at how they interpret MRI findings that are communicated to them by their healthcare provider. For this study, 14 patient-clinician encounters were analyzed. Overall, patients value the MRI report to identify their condition, but diagnostic closure, of course, cannot always be reached. Clinicians struggled with how to communicate soft findings when a structure-based diagnosis could not be identified. Speculation and discussing non-visualized structures or pointing out incidental findings were found to actually strain the therapeutic alliance. Overall, clinicians should limit their use of MRI as a visual aid unless it is germane to the diagnosis at hand. There is other recent data showing that how we communicate the findings on an MRI report can have a significant impact to the overall outcome for a given patient. This recent study compared the medical reading of an MRI report, literally word for word as to what the radiologist wrote, versus a simple language interpretation by the clinician. Not surprisingly, the simple language version led to a better outcome of the patient regardless of treatment. This is a paper that we reviewed on RRS as a research review, but it just stands to reason that how we interpret and communicate the findings from imaging can have an impact on how patients perceive not only their healthcare condition, but also the resultant prognosis and perhaps even what treatment they should seek for their condition. Ultimately, the decision to seek imaging boils down to its value versus its potential for iatrogenesis. It's well documented that imaging does not improve clinical outcomes for most spinal pain conditions. A further recent cohort study with 650 women, average age 61, so an older patient population, showed no relation of radiographic findings to low back pain-related disability. Older age alone, just for the record, is not a reason to seek imaging. As always, you have to put all the pieces together in their clinical scenario to arrive at a patient-centered appropriate decision. Here we need to heed the evidence, make an informed decision for our patients, and deal with the individual in front of you based on the factors at play for their current scenario. It's integrating their clinical history, risk factors, the presence of red flags, your comfort level as a practitioner, or the need to rule out serious pathology before you proceed with care, and so on. Ultimately, as I just said, this is an individualized decision, but we have to pay attention to evidence and the constant messaging that we're doing too much imaging for spinal pain patients. So how do you summarize best practices for the chiropractic care of older patients? Well, with my opinion, of course, but I'd like to think it's informed by the literature itself, lots of clinical practice, and everything I've done while looking at putting this course together. First, we need to address any accessibility issues at your clinic. Make sure elderly patients who may be a little bit physically disabled can easily navigate your layout, steps leading up to your clinic, and so on. Second, and I think most importantly for elderly patients, spend more time with them. Their initial appointment often presents a complicated clinical history that may require more of your time to appropriately get through. Further, I remember having lots of elderly patients who simply take more time to get from the front desk back to your treatment room, get into their appropriate clothes that they have to wear for treatment, get on and off the table, and so on. It's okay to spend more time with them. For most of us in clinical practice, our time is ours, and we can use it as we see fit. I think our older patients deserve a little bit more of it. And based on the patient expectations and outcomes literature that we discussed, I think elderly patients will really appreciate it if you do that. Third, be as comprehensive as you can within your comfort and scope of practice when dealing with a multimorbid patient, for example. You can also modify your treatment provision accordingly based on their stature, stiffness of their joints, their tolerance for manual therapy, and so on. Also, make sure you communicate efficiently, effectively, and in a timely manner with their other healthcare providers. This can really smooth out their healthcare experience, and it's one of the most common complaints I hear in practice from elderly patients, that their doctors don't talk to each other. Don't be part of that problem. Make sure you monitor these patients mindfully and carefully. As I've mentioned, many of them have multi-morbidities for you to deal with and keep an eye on from a peripheral neuropathy perspective, a blood pressure perspective, balance and their general risk of falls, and so on. Each individual will have their own collection of signs, symptoms, and conditions for you to be aware of throughout their course of care. Also, and obviously, follow the evidence in this space. As I mentioned earlier, we have some really exciting data coming out to be published in the literature in coming years that could really change the game for us in our chiropractic research space relating to the care of elderly patients. And finally, this seems obvious and something that we talk about a lot as a profession, but treat the whole person. Be a good resource for them, communicate clearly, and be a positive part of their day. This advice could go for patients of any age, but I think the value is a lot higher for older patients in how you deal with them in your clinical practice. That concludes the section on chiropractic care for elderly patients specifically. In the coming sections of this course, we'll start dealing with more specific conditions, including osteoarthritis, lumbar spinal stenosis, and degenerative cervical myelopathy.